Good evening, everyone. Welcome to a very special episode of Gyan Pravah, an intellectual stream of thought and innovation, conceptualized by none other than the FOGSI President, Dr. Sunita Tandulwadkar, an icon of endoscopic excellence herself. Today's episode is part of our distinguished series, Scope Room Stories, where we uncover journeys and pearls of wisdom from most revered endoscopic mind across the globe, Professor Sergio Haimovich. So before I start introduction of our guest, I would like to introduce our visionary leader, Dr. Sunita Tandulwadkar. It is with immense pride and admiration that we have Dr. Tandulwadkar with us today, the dynamic and distinguished President FOGSI, one of the largest federation of gynecologists across the world. A pioneer in field of gynecological endoscopy, ART, rejuvenation medicine, Dr. Tandulwadkar is name that evokes excellence, innovation, and unwavering dedication. She has been torchbearer of advanced minimally invasive surgery in India, settling global benchmark in hysteroscopy, laparoscopy, and even fertility enhancing procedures. Her journeys has not only transformed the surgical practice, but also redefined how the women's health is approached with compassion, precision, and scientific rigor. Dr. Sunita Tandulwadkar has had several key leadership positions in nationally and international association.
Sejal, today is the day of you and Sergio.
Sir, Madam, one line, Madam FOGSI Presidency, she leads with a rare blend of grace and grit, elevating standards of women's healthcare in India while strengthening global collaborations. Her presidential initiative, this Gyan Pravah, is a reflection of her belief that knowledge must flow freely, empowering every clinician every day. So we welcome you here, ma'am, for this wonderful episode with
Thank
Professor.
you, Sejal. Thank you. First of all, Sergio, welcome on the FOGSI platform. The great friend of years, the passionate and hysteroscopic surgeon. Our friendship goes long way, and it is so pleasure that when she said, I'm doing the podcast with Sergio, I said, wherever I'm in a transit journey to EBCOG, but I said, I will be here with you all. Sergio, this is every day, 8 p.m. We do this podcast series. I have 30 committee chairpersons. So 30 committee chairpersons have been given one day of the month. And that day, they interact with the leader, academic, non-academic, spiritual background, philosophical, political, spiritual, so many. And I felt this is because these are our future leaders of FOGSI. They will be able to, with the podcast, 45 minutes taking interview, you evolve them with their oratory skill, their introduction, their interaction with the national, international faculty. But believe me, we have crossed 130 and more than them, I got evolved. Every night meeting some talent from the world. There is so much to learn from them. So many different people, these 30 committee chairpersons have taken out from different backgrounds. And I felt I met so many new friends and I learned so much from their life. They were from non-academic, non-medical backgrounds also. And it's tremendous. So this Star Pravaha or a Gyan Pravaha series is helping me more than my chairpersons. And thank you for being here. And Sergio, FOGSI is always, entire FOGSI is your friends. All the leaders are your friends. India, you say Barcelona and you say Israel, but India is your second home.
Thank you.
And Sejal, if you excuse me, we have a boarding to go. And I will love to hear this podcast from the viewers link. Once I boarded, I'll join you back. Our thank you. Our way is Sergio. Only you and Sejal will be in the phone, and I join from another link. That's our way. So you both are highlighted, and it's today, it's evening of Sejal with Sergio. That's a good
Thank
combination. 3 S are here. Bye bye. See you.
Bye.
Thank you, ma'am. It's always
Bye.
honor to have you, ma'am. Thank you.
Thank you.
Welcome, sir, and I would like to begin this podcast with a short introduction of Professor Sergio Haimovich, the name that needs no introduction in the world of minimally invasive gynecology, is globally celebrated as one of the foremost hysteroscopic surgeons of our time. He is the head of reproductive surgery unit at Gyn Clinic in Spain, where his cutting-edge clinical work transforms patients' outcome every single day. With academic roots grounded in excellence, Professor Haimovich earned his PhD in obstetric and gynec from prestigious Barcelona Autonomous University. His excellence spans across the continents. As director of Europe, the Middle East, Africa, on the AGL board of directors, he brings international collaboration and insight to the forefront of gynecological endoscopy. He is also co-founder and co-chair of Global Community of Hysteroscopy, a transformative platform that connects thousands of gynecologists worldwide. Democratizing access to high-quality hysteroscopic education and real-time surgical dialogue. Professor Haimovich wears multiple academic hats as well, serving as an associate professor in Republic University in Uruguay and the clinical assistant professor at the Adelson Faculty of Medicine in Ariel University of Israel, reflecting his passion for nurturing the next generation of minimally invasive surgeons. With a career steeped in innovation, mentorship, and surgical finesse, Professor Haimovich brings more than just experience, he brings vision. Today, in this deeply engaging conversation with me, Dr. Sejal Naik, Chairperson of FOGSI Endoscopy Committee, he will share his journey, pivotal moments in his hysteroscopic career, stories from his scope room, and his vision of future of the hysteroscopic procedures. So sit back and allow the waves of Gyan Pravah to carry you into this world of one of the greatest minds in modern hysteroscopy, Professor Sergio Haimovich. Sir, we are more than honored to have you on this platform, and we are sure the viewers will see this episode again and again. So welcome, sir.
Thank you, Sejal, for the nice introduction. It's an honor for me to be here, and I'm very happy to collaborate with FOGSI in this amazing program you have here.
Thank you, sir. And shall we start with our first? It would be an spontaneous conversation between both of us. So let's see where this lead us. So, sir, your name is synonymous with the modern hysteroscopy. Can you take us back to the beginning? What drew you towards this subspecialty, and what kept your passion alive over these many years, sir?
Oof. Okay. It started when I finished my trainee period. During my trainee 25 years ago, during my trainee period, the only hysteroscopy I knew was in OR under anesthesia, even for diagnostic purposes. But then when I finished my trainee period, I noticed that I know a little of many things, but I really don't know nothing in gynecology. So instead of going to a big university hospital, I decided to go to a small hospital in which you did everything. I did obstetric, I did gynecology, I did everything. And when I say gynecology, I did endometriosis, oncology, everything, because I wanted to increase the pillars of my specialty. And while I was there wasn't any hysteroscopy, and office started in the late 90s. And we decided to start doing office without anesthesia. And you remember, it was with the alpha scope, a very tiny scope. And we started to do some diagnostic in office. That was the first time 25 years ago that I did with no anesthesia for hysteroscopy. Then after a few days, I finally decided to go to University Hospital in Barcelona, Hospital del Mar, and there wasn't any hysteroscopy unit. And I created the hysteroscopy unit, and the usual with grasper, scissors, just very basic. And one day, a guy from a company came to me and said, I have this small device. I don't know what to do with that. They can try. And he gave me a laser, a diode laser, and some fibers. And I started to go with the fibers through the scope, and I saw that I could actually use the laser in hysteroscopy, but I kept to him and I say, listen, these fibers are very, very thin, very flexible. If we create a fiber with these characteristics, I need thicker fiber, with a diamond point, and then so he brought me that, and I started to develop all the surgical techniques in office without anesthesia with diode laser. And my PhD was on that. It was a clinical PhD of the use in ambulatory non-anesthesia setup, the hysteroscopy, the diode laser in hysteroscopy. And then in 2009, we decided to open the first unit, surgical hysteroscopy unit, outside the hospital in a primary care center. It was the first in Spain. And we started to do everything there. Everything. Everything is everything. Myomectomies, whatever you think, we started to do there outside the hospital. And I didn't have any mentor. And that's a good message for all the young people that listen to me. I didn't have that opportunity that you have today. You have mentors that they can teach you. I didn't have that. But my best advice is you should compete every day, not with anyone but yourself. You need to compete with yourself every day to become better. And what I did is just I was competing every day with myself in my hospital. Never went to international events, congresses, and after some years, I decided to go for the first time to the European Congress. And for the first time in my life, I wanted to see where I was in my level related to the other in Europe. And for the first time in my life, I was looking back because I saw that by competing with myself every day, my level was very high. And you need just to compete yourself, and you will see that you will become an excellent surgeon.
So, sir, two key points. One, you need to have a broad and very strong foundation base. We need to learn the all basics first to move on to the excellence, and second, compete with yourself, because your best challenge what you have in your life is yourself.
I agree with you. I cannot teach anyone how to remove a 5 centimeter myoma. I believe that no one can teach how to remove a 5 centimeter myoma. I can teach people only the basic. I can teach them first how to use the scope, and then how to do basic surgery, how to remove a small polyp, how to remove a small fiber, how to deal with very light additions. To go from basics to complex, there is no shortcuts. It's a learning curve. It's you, time, and experience. Just to compete with yourself every day. You start with 4 millimeters myoma, you move to a 7 millimeters, then 1 centimeter, then 1.5 centimeter. In time, you will do the 5 centimeters. No one can teach you that. You can learn some tips and tricks, but you need to develop your own skills. And that's a learning curve.
Very wonderful, sir. Sir, as a co-founder of Global Community Hysteroscopy, so how this initiative came into your mind, and what was the vision behind this initiative, and how it is impactful to like worldwide? So how you are collaborating each one across the country, and whether it is towards in a correct direction moving ahead, and are you satisfied with it? So something about GCH.
No problem. GCH actually started from friendship, and my friendship with Luis Alonso, he's the other co-founder. We were in a course in Berlin I think it was around 2015. No, yeah, 2015. Yeah, 2015. And we said, do you imagine sitting in a room with all those big names of the hysteroscopy in the world? Those that you read about them, but you don't know them. And we decided to try that and to do a global meeting in Barcelona in 2017. And it was a great success. All the big names came. And that's how it started, just because we wanted to see the big names. But then our philosophy was that most of the big companies, and that the companies they are investing in continuous medical education. They give a lot of money, the industry, They are focused in United States and Western European countries where the money is. So all the best courses are there because there is money of it. And we thought that we need to do something for the 90% of the population because this United States and West European countries is less than 10% of the population. And we decided we need to do something for the 90% of the population that no one is doing. And that's how we started to be more focused on, I usually come to your country a lot. Last month, I was in China. I was in Taiwan, Singapore. We decided to work East Europe with the 90% and to focus on them. Last month, we opened a training center in Mexico for all the Latin American countries. They are low resources countries. So we are focused more on increasing the level in those countries that they don't have the privilege of having a high income and they don't have the resources. That's the philosophy of GCH.
Oh, sir. So reaching unreachable, kind of. Wonderful, sir. It's very impressive to know all about it. Sir, as you have already said that you can teach in a training program the basics, right? The advance and the skill and other practices makes them the perfect. So how, like in today's era, everyone wants to like copy paste the procedure, like, they all are available on YouTube videos and it's easily approachable, the learning materials. So the newcomers who are coming with aspiring towards the learning the hysteroscopic skill, they just see some videos and they copy paste. Try to do that in their OR. So is there any like other philosophy behind learning this technically really challenging, though simple? But maybe sometimes it's very deadly complications of having the hysteroscopic procedure. So, sir, what is your advice?
First, be calm because when you are with trainees and they always say, let me do, and you know that they are not skilled enough to do. So calm, and the learning curve is the learning curve. We are now using a lot of simulators because your skills can be developed in simulators. And then you can go to try and try with a patient. Another thing I always explain to trainees is don't take the word of your mentor or your professor as the word of God. Question it. Question yourself about everything you see and you see others doing. For example, when you go into a surgery, I remember always do a C-section, for example, and the trainee, he's used to be with many different specialists, from the different seniors. And the first thing they ask you is, how do you like me to perform this surgery? Which way? And I always answer the same. You can do it as you like. I don't care. Just do it as you like. But only one condition. When I ask you why you are doing that way, you always have to give me an answer for that. Because the first person that described the surgery, he thought about each one of the steps. And there was a reason for doing it that way. So if you explain to me the reason, I will accept that. It's not copy-paste. It's understanding. And if you understand something, you can find better ways, safer ways, and maybe faster ways to do the same. That's why I always tell them, don't take my word as the word of God. Ask yourself if you can find a different way to do it, because that's the only way we can improve what we are doing. Because if we stay all the time doing the same, we'll never improve. It will stay the same. And we need to advance and do better and think about different devices. The base of surgery from my point of view is creativity. It's not copy paste. It's to think how you can give an answer to an unmet need in surgery. Maybe you can think about a device. Maybe you can think about a new technique to do something. And we see all the time new techniques coming, but they're coming because people question themselves and try to find different ways. And that's the philosophy. Ask yourself, trying to find different ways, and always do, not because you're copying, ask, because you need to do it because you understand what we are doing.
Correct. So you should justify the reason why we are operating, how we are operating. In each step, there must be a reason of following that step for that particular patients. Sir, as you have just mentioned about the new innovations and new techniques evolving over a period of time in hysteroscopy. So which evolution you feel in hysteroscopic technologies like is a benchmark event, and where do you see the future of that holds?
We have now a lot of different new toys, and we like toys. You know, surgeon likes new toys. The thing is that there is no ideal toy. There is no one toy or one device that it's ideal that you could do everything with that. I think that the ideal surgery many times requires more than one device. And I teach my trainees that before they go into a surgery, to think about what are the different options or difficulties they may find, and just to bring into the OR any tool they think they might need in their during the surgery. And sometimes we start with one and then we move to another one. And that's the beautiful thing that of the situation right now, because we have mechanical instruments, we have mini resectoscope, we have laser, we have different tissue removal systems. You have a lot of different kind of tools that you can use during the surgery. And you have to think about, again, the creativity. I give an example. There was a 24-year-old woman, nulliparous, that she had pain and bleeding, and she came to our department. I performed hysteroscopy, and I saw bulking protrusion on the anterior fundal wall of maybe 1 centimeter. And the ultrasound showed that she had an 8 centimeter figo 2.5 fibroid. And she didn't want to do it through laparoscopy. She didn't want open. She insisted, and she wanted to do it by hysteroscopy. I told her, we will need many different steps in order to reduce it's bigger than your uterus, that to reduce this kind of fibroid. And she insisted. So I started with the resectoscope, the normal, the one that you all use. And when I passed the resectoscope 2 times through that fibroid, I saw that the consistency of the fibroid was very, very soft. I asked myself, maybe it's not a fibroid, maybe it's an adenomyoma. I didn't know that, but it was so soft that I asked for 2 things. Bring someone with an ultrasound and give me the morcellator. And I went with the morcellator, moving all the time around 360 degrees with the window toward the fibroid. And the guy with the ultrasound from above told me if I was very needy serosa, because I didn't want to morcellate the bowels. And in one session, we reduced 76% of the mass. And she needed only a second step to finish that procedure. That's why I say that you start with one, expecting one thing, but you should to expect the unexpected and be ready for everything when you go to R.
So the surgeon must be having the all wide experience and the equipments ready to deal with such a variety of cases. As you evolve in the surgery, as we grow and become more wise and more experienced, we understand which tool is best for this patient. And
Right.
that's why we also incline to have everything in our OT.
And another important thing for the young people is always know your limits. Always, because if you want to avoid complication, you need to know where are your limits, and don't try to go over your limits, because that's the first step for a big complication in OR.
There is always a small faint line between the safety and the crossing the limits. So this is very wise advice that one must constrain. Better to have 2 sittings in such a patients where you feel that we are not competent enough to finish in one go. That is patient safety first.
There are 2 moments in physician life that there are more complications. First, at the beginning. Why? Because you don't have experience, and that's why you might have more complications. And then when you are very good, because you are overconfident and you think that you can do everything, as I try to do 8 centimeters submucosal fibroid type 2, because I thought I could do that. But if you don't take, and I had my complications being in this stage of my development as a professional. But listen, when I started to do, the first thing I asked for was an ultrasound because I know that there might be complications. So you learn with your complications, and once you do a complication, then you try to avoid the complications. And that's another thing. Learn from your mistakes, learn from your errors to try not to, because everyone can perform a mistake. No one is perfect, and you will have complications, but you have to learn from each one of them in order to not repeat them.
Through overconfidence and over enthusiasm, both. And then usually we miss to diagnose that on the time when we are having it. Sir, let us continue with this conversation. I still wait for your answer on where the future of hysteroscopy technology you see. So
I will tell you that 1.5 years ago in Nashville, in the United States, I tried the prototype of a hysteroscopy robot with 2 arms. You could walk with that inside the uterus. And one arm, for example, it was a myoma, pushed the myoma, the other with the laser cut the myoma. I don't believe it's going to be a future because it's too expensive. Maybe they can afford that in the United States. I doubt that. But we try to find new devices all the time. And the practice of hysteroscopy is completely different in every country. You know that in India you have a better level than the United States of hysteroscopy. Yes. And I say no in that, and I told the Americans the same. I always tell them, you know that in India they have better level, because in the United States, the medical director of the AAGL 2-3 years ago, she told me that hysteroscopy is dying in the United States, and it's a very, very heavy things to say. And I started thinking. I went to the exhibition hall and I came back to her and I said, no. Hysteroscopy, as you know, is dying in the United States. No resectoscopy. They are losing the skills of resectoscopy in the United States. And I told her, if you go to the exhibition hall and you see how many companies of morcellators are there, you will understand why is it happening. Because people always try to do fast, easy, and using a morcellator is very, compared to to do a resectoscope, the level of skill is much lower. You need to have skill, but much lower, and you can do many things with that tool. And it's I call it it's hysteroscopy for dummies, because you don't need to know surgery. Just put that near the polyp and it hits the polyp. And due to that, they are losing skills. In your country, the base is still resectoscopy. You are very skilled in resectoscopy. That's the base, because you don't have the resources to have so many morcellators. But it will change. When I was in China last month, there are so many companies coming with cheaper devices, and I think it will change slowly. But we need to keep, even the technology is coming and it's changing our way of working. You need to keep those skills of resectoscopy, because the morcellator it's a good tool when everything is easy and no problem. But when you have a difficult, complex case, the resectoscope will be there, and the resectoscope is very efficient in those cases. I don't think that you will be able, still with what we have today, to remove 5 centimeters type 2 fibroid with a morcellator. You still will need the resectoscope. So don't lose those skills. Even that technology is changing the way we are working.
Yes, sir. Rightly say we have a large number of patients load, so that may be probably shortening our learning curve a bit with the vast experience in a shorter duration of practice. Maybe that may be the reason why how the hysteroscopy, and there are so many takers also. Whenever we have a good hysteroscopic program, it's always houseful. So people are like, doctors are also very inclined to learn this skill, and we appreciate it's being a truly very minimally invasive, no scar, no hole surgery. So even the patients now, over the last 15 years, what I have observed, they have shifted, they have understood, they have accepted the minimal invasive ways of the procedures, and they are willing to preserve the uterus as far as possible. So we definitely are moving forward towards the more evolutions in hysteroscopy procedures.
But you still have a long way to go in office. Office is,
Yes, office.
we started without no many years ago. When I started to come to your country was 2016. People were just starting to see office. And I say to see because they came to see, not to do. And it's difficult to make people start doing because they are afraid of many things. I call it mental barriers that people have before they start doing. They're afraid that it's going to be painful for the patients. They're afraid that if they're outside the OR and they have a complication, what will do? But there are no complications. If you know when you develop a skill, it's not painful. But it takes time. I know it takes time. We are doing a great work. You are doing a great work. And slowly, the office procedure will have their own place in your practice.
Sir, as you are the intercontinental person, you are traveling across the continents, and you might have observed the diversity of settings and the patients. So how you are balancing each places, and what is your the ultimate take home for us, that how these kind of different diversity that you have been working can guide us to move on, and how this experience can have
There are differences in between countries. First, on the health policies, that some places that the public health, like in Spain, everything is for free. They invest a lot of money. There are places that only people that have money they can have the good medicine. I think the extreme example is United States. If you don't have money, you don't access good medicine. It depends on those factors, and then it also depends on if anyone is teaching you. If there are some people in your country with those skills that can help push in the country those new ways to do some procedure. In your country, in your case, it's a huge country, so there are skilled people, but because it's a huge country, it takes time. You really have skilled people in office. I saw Sunita doing surgery, Krishna Kumar doing surgery. There are many people that are skilled in office procedure, and in very good and very advanced hysteroscopy. But due to the characteristics of your country, it takes time. You have many different societies like FOGSI that they invest time and invest resources in helping people to reach the level, but still, it's a huge country and it takes a lot of time. I believe that in the big cities, people are luckier because in big cities, they have more centers, more resources, but the characteristic of your country is that not the biggest proportion of the population is still not in the big cities, but it dispersed around a huge territory. And that's why it will take some time. Unless you create a continuous medical education system that may help people to reach those far areas. But I know that most of the programs in your country are focused on big cities. And that's one of the characteristics in your country. You can get in Mumbai or in Delhi very good medicine, very high level medicine. Again, if you have the resources for that, compared with other places, because there are a lot of competition there. There are very good centers and very good professionals. I believe that your society, and I don't know what they are doing, but from outside, your societies, you work more closely with politicians. in order to find how to do it in different areas. And I will give you an example. There is a small country in South America. I am professor in University, Uruguay. I was born there. That's why I'm connected to this country. And this country is, they have only 3.5 million. The population is 3.5 million. Half of them, they live in the capital city. Just half of them. And the rest are dispersed in a very big area. Because in South America, there are even small
Yes.
countries that are in areas that are big countries. And all the good medicine is centered in the capital city. The name is Montevideo, all the good medicine. And people from all over the country, if they want medicine, they have to travel to the capital city. The government pays for the travel expenses in order to come. But the problem is that they have to move many hundreds of kilometers, and they have to wait long waiting lists because preference is for the local in the capital, and that's a huge problem. So I saw that, and I decided I have to help the country to change that. When we are working right now with politicians, with the National Society of Obstetrics and Gynecology and the National Society of Gynecology and Endoscopy, and the idea is to create different units around the country in which we do first train the trainers. We train people to be trainers in those places, and we give the resources, the starting resources, and by that we will allow people that living not in the capital city to reach good medicine and to reach hysteroscopy in this case, because I cannot understand why a woman has to wait 1 year for the diagnosis of endometrial adenocarcinoma. So and that's what happened in there. So by this program, and it doesn't require a lot of resources, because when you buy a device and you are the government, you don't pay taxes for that device, and everything becomes very cheap, and they can do it in a very cheap way. And by this, they can increase the level of medicine around the country in those areas that they don't have the privilege that people have in big cities.
Oh, such a huge work, sir. So health policies that decide the medical, the funding from where it comes, it's not only the surgeon skill, you need everything so settled around to have the best quality care to our women.
And the key to success with politicians is to give them votes. So if you do something, bring the project very well designed, so he can come in front of the cameras and say, this is my project. I decided to improve the quality of life of my population, and he gets the votes. That's what they want. I don't care. I give them if I can increase the level of of assistance to those populations.
Yes, so truly said, so amazing and so frank and so, honest opinion, sir, we received from you. Thank you so much. And if time permits, would like to have some few, one word answer or the rapid fire questions kind of thing. So, sir, out of everything, plethora of instruments you have for hysteroscopy, which is your favorite one?
I still think that my laser is my best tool. And the characteristic of the laser, when you do office without anesthesia, the dispersion of the heat is only 0.5 to 1 millimeters. They don't feel the energy. And the great advantage is that it cuts in a very efficient way, but at the same time, it coagulates. So there is no bleeding during surgery. And I think that's the best. But for example, for me, for RPOCs, big RPOCs, the best is the tissue removal system. Because our big RPOCs, even 5 centimeter placenta, you can remove it with the tissue removal system in minutes. So it depends also on the procedure. For small polys, my best tool are my mechanical tools. I use the scissor and the grasper. So it depends on each procedure, but the most versatile one that I'm using right now is the laser.
Okay, sir. Sir, if you wish to give a credit to one person in like that who has changed your life in hysteroscopy, who would you?
I'm now in a position to say that there wasn't one person. First, I didn't have any mentor, but I try to learn for each one of the people I met in my life. So I read the works and I try to improve the works. I give you another example. In 2009, Betoki, he published a paper called Opium Technique. Opium states for Office Preparation of Partial Intramural Myomas, in which he did a first step of the surgery of the myoma in office without anesthesia, with the bursa point cutting around the myoma. And then the second step, they send the patients into OR to do resectoscopy in the traditional way. When I saw that in Barcelona, I thought, why to do a second step on OR? Why not to do everything in office? And I tried. And the first time I tried was an anterior fibroid around between 1.5 and 2 centimeters, and it was and did the enucleation of the fibroid. The fibroid, the small ball, white ball, fell into the cavity, and I did that. You can do it in office, but then I had a problem, and I thought, oh my God, how can I take it out? I'm working with a 4 millimeters optic, and it's 15 millimeters fibroid. How can I take it out? And I learned from that. I did a very responsible thing. I just left it inside the cavity. And when I did an ultrasound, it wasn't there. And I saw, oh, a miracle. God helping me. A miracle, the myoma disappeared. And then I tried again. And again, the fiber disappeared. And it became a publication showing that you can leave the fibroid inside the cavity free. And in a 2 months after follow-up ultrasound, 100% disappeared. It was very criticized by Betoki and many other colleagues, and it ended in a study that was led by Tanvir Singh from your country, for Hyderabad, in 7 countries, 9 centers, more than 200 patients, showing that you can leave it inside in a safe way. So you learn from each one of them, and you try to improve. What you read, it's, as I say, it's not the word of God. I saw that paper and I thought maybe I can improve it and do it in another way. And each one of the people I met in my life, they had an influence in me.
So excited to listen the story, sir. It's really, sir, if you are not a gynecologist, what you would have been?
Oh, I don't know. I don't know anything else. The good thing about us, those that love their work, is that you don't go every day of your life to do something that you love. And I don't feel that I'm working. I think that's like a hobby for me. I enjoy every minute. And that's a privilege that not many people have in their life. People that work in an office and they do every day, they don't enjoy. They have to do it because they need to live. But we have the privilege to do something that we love. And for us, it's not working, it's enjoying.
So nothing else than the hysteroscopic surgeon.
I hysteroscopy and a little laparoscopy, I think endoscopy. When I was a trainee, I thought that there were 2 fields in our specialty that will have future. One was the pelvic floor, incontinence, and the second one was gynecology endoscopy. And I didn't like the pelvic floor, so I went for endoscopy, and it had really a future. And I was right, and it still has a future. Next Congress of the AGL in Vancouver next November, more than 60% of the Congress is on AI, artificial intelligence. It's changing our way of working. You don't know how much it's changing our way of working, and how much it will change our future. That's the new revolution, or technological revolution after the internet. And I think that we will see different ways of working, and more interesting and more funny way of working.
Yes, sir. Sir, any thing you would like to change in your life, like any advice you would like to give yourself at the age of 30 you were, or somewhere around?
I think that if I could change something in this world, it's to remove ego from people. I'm not consider myself an ego person, and I think that one of the things that are difficult, the development of surgeons in life, are the ego bosses, a boss with a big ego, or people around you with big ego, because they, instead of letting you develop, they try to push you down. And if something I would change is to remove ego from our life.
So wonderful talking to you, sir. It was really very interesting to know you, the other side of the surgeon, and thoroughly enjoy, sir. And I'm very sure our viewers would have the same feeling, sir. So, sir, thank you so much for spending your time. And last word for our newcomers, our new aspiring endoscopic surgeon, your advice, sir.
Thank you very much, Dr. Sejal. I really enjoy. And my final advice is try to be better. You try to be better, compete with yourself, try to be better. If you love what you're doing, just try to be better. You will reach very far away goals in your life if you try that.
Amazing, sir. Thank you. Thank you so much, sir. Thank you, Dr. Sunita Tandulwadkar, Madam, FOGSI President, for giving this such a wonderful platform to us. And thank you, Evangel team, for this technical support. And thank you, sir, once again. Thank you.
Thank
See you,
you
sir.
too. Thank you for my good friend Sunita. She's doing amazing work in FOGSI. And I really enjoyed this interview with you, Dr. Sejal.
Yeah, see you, sir. See you somewhere or maybe in Vancouver.
Thank
See
you.
you, sir.
Bye.